This is Dr. Bernstein with our November 2017 teleseminar. Before we begin, I want to remind you that the answers I give are geared for the general audience and may not really solve the problem of the person who's asking the questions. The reason for this is I haven't examined that person, I haven't taken a full history, and I'm just guessing at an answer. But it does give you a chance to see the logic involved in coming to a tentative conclusion. First question. I'm a female, 58 years old, 120 pounds. I was a gestational diabetic. If I eat a half cup of ice cream, my blood sugar is over 200. My fasting blood sugar is usually between 112 and 119. I've reported this to my doc, but she thinks my levels are okay. How can I convince her that I really have abnormal blood sugars? Well, probably the answer is to get an oral glucose tolerance test, which she can administer. You drink 100 grams of glucose in a solution, and it's a purchase solution that comes in a bottle. And many doctors can administer this test, and then they do fingerstick blood sugars every half hour. And if after 2 hours you're over 200, you're by definition diabetic. If you're over 146, I believe you're called pre-diabetic or something like that. So that's probably a good way to convince her. I started Victoza less than a month ago, and my blood sugars went down immediately. I increased the dosage on Monday, and they have gone down even more. Can you please comment on the pros and cons of Victoza, whether it is easy to come off it, possible adverse effects, permanent damage, etc.? I don't think you could call it an addicting drug, and the main long-term effect is the possibility of pancreatitis, which is a very low possibility. Now, the American Diabetes Association and other organizations that accept paid advertising from the manufacturer say that pancreatitis from this drug is impossible, but I've seen it on 3 people so far. What you could do to play it safe is ask your doctor to check your serum levels of pancreatic lipase and pancreatic amylase periodically, maybe after the first week and then after the first month. And if they become elevated, or even if they increase, you have a warning. Hopefully you won't have symptoms, which are usually abdominal distress. But again, this is quite rare. I use Victoza for my patients who cannot control their overeating. I use it to control appetite. And it can be quite effective for about half the people you try it on, and therefore a very valuable tool in controlling blood sugars. The direct effect of Victoza on blood sugar is marginal, it's quite small, but the effect via appetite can be considerable. The one catch, however, is that many of the people who use it, not all, but let's say about a third, develop a tolerance after a while, and their appetite returns. So even then, you can switch to a similar agent like Byetta and not have a tolerance to the Byetta, and then wait X months or a year, and if you become tolerant to the Byetta, you might be able to go back to Victoza or maybe even to amylin. All this is covered in my book, Diabetes Solution. My daughter is 13, diagnosed in February of this year. I found your book, so we've been eating a low-carb diet. Her levels are between 81 and 135 milligrams per deciliter, but she gets into the low 90s, gets dizzy and ill-feeling. Her numbers were getting lower and lower when we changed her diet to low carb, and is currently on no insulin. Should be taking any, and what, how, and what would be best? Well, first of all, if she's getting symptoms of hypoglycemia, I assume that's what her symptoms are when she goes into the low 90s, it's either because she was used to higher blood sugars and has to eventually get used to normal blood sugars, or her meter may be reading higher than it should. And most meters that are sold today are grossly inaccurate. The one meter that I found to be accurate, the Freestyle Freedom and the Freestyle Freedom Light, is good up until blood sugars of 115 or so. So near the normal range, it's a very accurate meter. But even when you get up near 120, it becomes inaccurate, as all the others are. So you must have an accurate meter. And then she should eventually be comfortable with blood sugars of 75 or 80 for a 13-year-old girl. That's basically the best advice I can give you right now. Hopefully she'll get used to blood sugars of 75 or 80. My boyfriend raced his bike 8 miles home after work at 6 p.m. with a blood sugar of 101. When he got home, his glucose rose to 177. He did not take his R insulin before biking to ensure that he would not be delayed for any reason and go low. How can I help him smooth this evening rise? He had 3 units of R at 1 p.m. and Levemir and 3R at 5 p.m. I'd suggest that you get my book. It sounds like he's doing random things that may not relate to his actual blood sugar needs. He's taking Levemir once a day, and it's an insulin that, if given in physiologic doses, should be given twice a day. To make it really long-acting, you have to give possibly double the dose that you need, and this can be causing you problems. So I'd suggest read my book, if possible, to switch to Tresiba insulin and give it twice a day on arising and at bedtime. And you should have less problems if you do that. A friend with type 2 diabetes gave me a copy of your book, which I am reading to control my blood sugar. They inject insulin after meals, not before. Is there any risk in doing that? Well, if you have severe gastroparesis, as many type 1 diabetics do, you may be wise to inject after the meals. But your friend is a type 2 diabetic and may not have gastroparesis. Why your friend is injecting after meals, I'm not sure. What we want to do is keep blood sugars normal around the clock, and for type 2 diabetics, that may not be the answer. So I'd suggest that you read the book very carefully and take the insulin as needed based on your blood sugars. So you may need it before, you may need it after, you may need it during. Most of my patients take their insulin before meals. People without gastroparesis may take it as long as 45 minutes before a meal. Another potential problem is many people use insulin that's too powerful and too rapid acting, such as Humalog or maybe Novolog. And that works so fast that you might have to take it after a meal. But it's so potent that it's hard to get a dose that leads to fine control of blood sugar. I have a teenage type 1 girl and borderline type 2 myself, kept in control by low-carb diet. How can we use hemoglobin A1C to judge our success over time? What is a good target for type 1s? Well, as I've said for years, what's important is blood sugars. That's more important than the hemoglobin A1C because there are certain catches in the accuracy or the significance of the A1C. If you're typical, you might want to have ideally an A1C in the high 4%, like 4.8, 4.9%. But I would concentrate on blood sugars. If you're checking your blood sugars frequently, including in the middle of the night from time to time, you'll have a more accurate picture of your blood sugar picture than a hemoglobin A1C can give you. What do you recommend for cramps? Am type 2 on Tresiba, 35 units a day, and Glucophage, 2,000 milligrams a day. Getting feet and hand cramps since recently starting Tresiba. There are so many causes of cramps. You could go to Wikipedia on the internet and find all the causes for muscle cramps. I can recite some just off the top of my head. If you're taking a statin, one of those drugs to lower cholesterol, very high incidence of muscle cramps. If you're dehydrated, not drinking enough fluid, you could get muscle cramps. If you're hypothyroid, as is the case with the great majority of diabetics, both type 1 and type 2, you could get muscle cramps. So you might want to, on the remote chance that the culprit is the Tresiba insulin, you might want to go back to the Levemir, if you were taking that previously, and see if the muscle cramps go away. How does the ketogenic diet compare with yours for type 2 diabetics, and do you recommend it? Well, everyone's definition of the ketogenic diet seems to be different. Dr. Atkins originally recommended a ketogenic, what he called the ketogenic diet, for obese people to be able to track whether they're metabolizing fat. Because when you metabolize fat, you produce ketones, and you can measure ketones in your urine. So as long as you have ketones in your urine most of the day, you're burning fat. Do I see a purpose in measuring ketones or producing ketones in the treatment of diabetes? Not really. I haven't measured my urine for ketones since I started measuring my blood sugar in 1969, because it's impossible for me to get ketoacidosis doing what I say you should do in my book. So why should I be measuring ketones? In fact, most humans, when fasting, will produce ketones in their urine, and many humans, just by fasting overnight, will awaken with ketones in the urine the next morning. So I just see no point in testing now. Then, what is a ketogenic diet? I've seen different versions, different books, different internet sites, and the one thing I've seen many of these advocates, especially people who are selling books via the internet, they seem to advocate a lot of fat, frequently fruit, which is certainly not good for diabetics, and frequently too little protein. So I've seen people come in pretty poor physical condition on so-called ketogenic diets that they had read about that were telling them to cut back on protein. This is a whole strange ball game with the same word being applied to a lot of diets. Over 50 years of age on type 1 blood sugar roller coaster, and I want to get off. Recently started Dr. B's plan. After dinner, my sugars go up to about 140 to 160. After about an hour or so, and then drop down to about 50 to 85. After another hour or so, day after day, I keep trying to adjust pre-dinner Novolog dose and timing for the same exact meal. But the above pattern is the best I can get. What should I do? Well, first of all, this person probably is not on my regimen. By taking Novolog, which I do not recommend for meals, would certainly attest to his not being on my regimen. I'd suggest that he read the book much more carefully. I really can't be sure of what's going on. It could be that it's just the timing of the insulin before the meal that isn't working right. But when you have an insulin that works so fast, you're bound to drop low initially and then go up later on. Recent studies that associate high inflammation and high blood glucose are being the least lethal combination. Once you get blood sugar under control, what additional measures do you need to minimize inflammation? Well, most people with normal blood sugars don't have to worry about inflammation unless they have special problems. So if they have frequent infections in the mouth, you certainly can get chronic inflammation. And I even think I recommended in the book that most people should take 100 milligrams of ubiquinol per day because it tends to be relatively protective against root canal and gum infections. There are certain diseases like rheumatoid arthritis which create chronic inflammation or on and off inflammation. And there are lots of tips in the treatment of diseases like rheumatoid arthritis. But to try to focus on inflammation per se is quite difficult. There are many blood markers of inflammation. There's so many that it would be pretty expensive to chronically keep track of them all. I am comfortably getting my BG to 95, my A1C to 4.9. My daily readings using Dexcom are always between 75 and 130. What are the benefits of lowering my BG to 83 from 95? As I've said many times, the all-cause death in diabetics goes up with blood sugars, and the lowest mortality in several studies appears to be about 83. Now, some studies were based upon fasting blood sugars of 83. Some were based upon the hemoglobin A1C when corrected to give a blood sugar number, and that's the best I can tell you. How much does mortality go up between 83 and 95? I don't remember the numbers or which study I'd be quoting. I'm a type 1 who is following your regimen. I have hard time keeping my blood sugar stable after a meal. If I take a half unit of regular insulin with my 12-gram carb meal and wait 30 to 40 minutes to start eating, my blood sugar will rise 18 to 36 milligrams per deciliter after my meal. It does come back after about 3 hours by itself. If I take 1 unit of regular, my blood sugar will stay stable for 2 hours, but then will go too low subsequently. Please advise. I'd advise you to read my book. You can adjust the timing of the insulin, not just the amount of the insulin. Next question. Muscle Milk Light, L-I-T-E, helps me during swimming. The 5 grams of carbs and 20 grams of protein keep me going. I load my calories and protein before and after 2 hours of swim. Is that okay? Well, I would say what works, works. I think Yogi Berra may have told me that. If that does the trick, fine. Is there any research we can present to our endo that support a very low-carb diet and will ease my daughter's anxiety about her self-health care decisions to not consume many carbs on a daily basis? Well, what you could do is refer your endo to Type 1 Grit on the internet, G-R-I-T, and 1 is spelled out O-N-E, Type 1 Grit, and he can see hundreds, if not thousands of people who are achieving normal blood sugars with the help of a low-carbohydrate diet. And he'll see that the Type 1s are growing, and these people are doing much better than what usually is found in the general population, or certainly the diabetic population. Now, if your endo, if her endo is not cooperative, you'd probably be wise to find a kindly family care doctor, someone maybe who her neighbors like, because these people tend to be more cooperative with diabetics than the endos. Most of the endos feel they have to follow the guidelines of the American Diabetes Association, and those guidelines are not geared to the survival of diabetics. They're geared to hopefully avoiding lawsuits. Suggestions for switching over to Tresiba insulin from pumping Humalog or regular insulin. How to decide whether to take only at night or night and then the next day. I suggest that you look at my book, Diabetes Solution, and assume that you're a new diabetic starting from scratch. It's as if you've unplugged your pump and are starting from scratch, and start there. One thing I would certainly suggest is that if you're using Tresiba insulin or any long-acting basal insulin, that you take it twice a day. The only ones I've seen who can get away with a long-acting insulin once a day is type 2 diabetics who are making a fair amount of their own insulin and can get away with covering only part of the day with basal insulin. Diabetic for 48 years on insulin. So this person is a survivor. Good control with split Lantus dose. So that means this person is taking Lantus insulin twice a day. I tried a Tresiba sample from the endocrinologist. Love it, but Medicare does not cover it. And Levemir, for the same reason, did not give good control. Should I be concerned about continuing with Lantus regarding the potential cancer risk? It's a hard call. But what you might first want to do is what we've done for our patients, and that is appeal to the insurance company and appeal to Medicare. It takes a lot of effort on the part of the doctor's office, but I have someone in my office who's succeeded repeatedly in getting Medicare to pay for Tresiba insulin. It takes an effort, takes finding the right person at Medicare and so on, but it probably can be done. Female 47, type 1. A1C is consistently at 5.1%. Have been on insulin for 9 years. Also hypothyroid. Following your diet. Rarely experiencing highs or lows. I switched to Tresiba from Levemir insulin 12 months ago. Love the flat lines. However, since I switched to Tresiba, I've been steadily gaining weight, about 5 kilograms, despite no change in diet. Have any of your patients had issue with weight gain on Tresiba? I'm considering going back to Levemir along with intensified weight loss efforts. Well, I've never heard of this. I switched to Tresiba a while back and my weight never budges. But you might want to, you are already hypothyroid, and it could be that it's just a coincidence that your switch to Tresiba corresponds to a drop in your serum free T3. So if your free T3 is dropped, I would expect you to be gaining weight. Also, you might be experiencing muscle cramps and getting tired if your T3 is low. So I take a look at that first, because that may be the answer. Are there any new monitors coming along with better accuracy than the plus or minus 15% we have now? Well, the one that I use is much better than plus or minus 15% when you're in the normal range. And that's the Freestyle Freedom. When you get out of the normal range, it, like all the others, loses accuracy. So we do have better than 15%, but that's only if you keep your blood sugars in the normal range. Why does Dr. B equate hemoglobin A1C levels of 6% to a blood sugar of 140, nearly twice his stated good target of 80? When charts I see online equate 6% to only 126. The reference that I use, which was a very good study, is cited in my book, Diabetes Solution. The subsequent study which was paid for by a large manufacturer of inaccurate blood sugar meters, generated results that were inaccurate. And the ADA chose to accept the inaccurate results, and there's a good chance that money was involved. I'm not an insider there, so I don't know what was going on, but I do know that the manufacturer spent a lot of money and was using one of the more inaccurate meters on the market. My endocrinologist is not very supportive of me using Novolin R, writing an RX for diluent or the low carbohydrate diet. Of course, I am doing it anyway and have been unable to secure a prescription for the diluent. Is there a network of endocrinologists who support those of us who want to take care of our diabetes accurately? I'm getting news that there are some endocrinologists in England who are impressed by patients who are using my book and are actually collaborating with them on prescriptions. You probably do not need a prescription for diluent for Novolin R. Your pharmacy can procure it without a prescription, so if you have a friendly pharmacist, you can get the diluent, or you can probably use sterile saline, injectable saline, which likewise you can probably get without a diluent. If your endocrinologist isn't cooperating with you, I suggest that you do what many others have done, and that is find a cooperative family practice physician who, for some reason or other, they tend to be more humane and less interested in satisfying the ADA. When you transitioned from Levemir to Tresiba, did you use the same doses, AM and PM? Yes, I did. I was thinking of taking only my AM dose for several days to see what happens to my fasting blood sugar. Is this reasonable? Well, if you're a type 2 diabetic, it might work. I don't expect it to work for a type 1. Type 1, 47-year-old female. Following your program, my endos challenge my tight control, referring to the Accord study. I've watched your Diabetes University video regarding the Accord and have looked at the article you recommend. Endos have not been able to accept alternative information presented by me. How do I respond succinctly to those challenges? Well, if you show your endo the retraction that appeared in the journal Diabetes Care, that's the clinical journal of the American Diabetes Association, where the conclusion of the Accord study, which was a phony conclusion, was an absolute lie, and they were forced by the lower level doctors in the study who did the actual work, the big shots at the top of the study who drew the conclusions, gave an ADA conclusion claiming that there were more deaths at lower blood sugars, where indeed there were more deaths at higher blood sugars. And the retraction appeared in the journal Diabetes Care, so you could show that to your endo. Now, if he's not willing to believe what he reads, then you probably have to do what so many other people are doing and get yourself a family care doctor. Type 1 for 10 years. I'm trying to minimize the cost associated with diabetes management, but not to the detriment of blood glucose levels. Well, I guess he wants some suggestions. One thing that I can suggest is low carbohydrate diet. That means that you'll have a lower food expense because you won't be overeating for hypoglycemia. You'll have smaller insulin doses, and insulin is nowadays expensive. You'll have less complications that have to be treated and cost money, and reduced hospitalization. All of these occur when you have normal blood sugars around the clock. So I'd suggest you read my book and have normal blood sugars. Regarding the use of test strips, I currently test 10 to 15 times a day. I'm still in the trial and error stage of your regimen. What would be the minimum number of tests per day you'd recommend for ongoing type 1 management? Well, it depends in part on whether you're making insulin or not. You'd have to check your C-peptide level, and if you're currently making insulin, there's a possibility that you could get away with 5 or 6 times a day. I usually would recommend on a rising, the initial recommendation when you're trying to work things out, on a rising, before each meal, 1 hour and 2 hours after the end of each meal, and at bedtime. You might also, if you get up in the middle of the night to urinate, you might check one in the middle of the night also. If you don't get up to urinate, you should set an alarm and occasionally check it in the middle of the night. Eventually, you might be able to get away with only checking your blood sugar before each meal and at bedtime and on a rising. That's if your blood sugars are really stable and level all the time. Of course, before and after exercise, and most importantly, before driving, and if you're in the car for driving for more than an hour, I would check it every hour while you're driving. My husband takes Glucophage and was admitted to the ICU with a serious urinary tract infection. The attending hospitalist said Glucophage is hard on the kidneys and can contribute to kidney damage. She recommended he not take Glucophage in the future. Can you comment? Yeah, he told her wrong. He told your husband wrong. That's utter nonsense. Does not cause kidney infections. In fact, I've used Glucophage on hundreds of patients, and I don't think one of them has had a kidney infection during my care. Do you have any recommendations on appropriate use of transdermal metformin gel? It gave me terrible diarrhea. This is not available commercially in the USA. You might, however, you should know that the oral metformin can cause diarrhea and has to be used in a certain way. First of all, I started with the slow release, the XR, and I use the brand name, not the generic. So I use brand name Glucophage. I use the timed release initially, even though eventually I might want to use the rapid release. And I'd take it at the end. I would have my patients take a small dose, the smallest dose, 500 milligrams at the end of a meal. That minimizes the likelihood of initial diarrhea. Then, if they do have mild diarrhea, we continue it for a couple of weeks, and usually the diarrhea stops. Not always, but usually. Once the diarrhea stops, we can add another dose at another time of the day, and eventually we can get away with the full dose, which if it's the XR would be 2,000 milligrams a day, or if you're using the rapid-acting stuff, would be 2,500 milligrams per day. But you have to do it in stages. Low urine pH, that would mean high acidity, is a feature in insulin resistance metabolic syndrome per a 2007 study. Most common sources of protein are acid forming rather than alkalizing. Is the correlation between insulin resistance and low urine pH accounted for in your diet recommendations? Urine should be acidic. It should not be alkaline. I don't know where this study came from. The reader did cite an internet source, but I don't believe that urine should be alkaline. I went to medical school and we learned that urine should be acidic. In fact, when we admitted patients to the hospital, we had to test their urine, and I don't remember anyone ever having alkaline urine. For those of us only with access to Lantus insulin as a long-acting insulin, would recommend splitting one total daily dose at bedtime to 2 doses, one at bedtime and one in the morning, to better combat the dawn phenomenon. If so, what doses and timing would you recommend? Well, it's like this person has reinvented what I invented probably 30, 40 years ago. When I was using ultra-lenti insulin, we found, which was a very good long-acting insulin, found that we had to split it between morning and bedtime, and I've been splitting it ever since. So this person, he should read my book, and he'll see that we certainly recommend what he's recommending, or she. I was recently diagnosed with prediabetes with an elevated fasting blood sugar of 106. Blood work shows fasting glucose down to 92 and a 5.3% A1C. However, my anion gap is elevated. Should this be concern? Will I develop diabetic ketoacidosis with lower carb intake? I don't know why your anion gap is elevated. We usually don't measure it routinely. And certainly diabetic ketoacidosis requires very, very high blood sugars and severe dehydration. Now, there is a possibility that you might be dehydrated, or that you might be on dietary sodium restriction, etc. So there may be dietary tricks that you're doing that can give you a high anion gap, but certainly diabetic ketoacidosis is not part of your ball game. Next question. Endurance athlete, 10 plus hours of training per week, regularly waking up in the morning with blood sugar of over 130 milligrams per deciliter because of night lows caused by previous day training. First of all, that's nonsense. That's going back to the phony Samoji effect that was never proven to occur, ever. I tried lowering insulin doses during the night, but doesn't work. How can I maintain steady blood glucose? I'd say you read my book and follow the diet and do what it says. You certainly would need a basal insulin, long-acting insulin, etc. On the other hand, you don't say whether you're a type 1 diabetic. It could be that you don't even need insulin, that maybe an oral agent might be of value. But certainly, you don't go up in the morning because you're low during the night, unless you overeat for the low. My 3-year-old daughter is type 1 diabetic. Please could you tell me how many grams of carb, fat, and protein she needs every day to ensure good nutrition and growth? Number one, I think you should read my book, but go to Type 1 Grit on the internet. Type ONE Grit, G-R-I-T, and you'll see what all the other kids on that site are doing. And it really is a matter of trial or error. What I do with growing kids is give them as much protein as possible without making them uncomfortable and feeling stuffed. And for a 3-year-old, you probably have to give her multiple small meals. They can't eat a lot at one time, so she probably needs snacks. And you probably have to give her a small dose of diluted insulin with each snack. But this is covered in the book, and the people on Type 1 Grit should be able to help you out. They actually will answer your questions, but you'll see examples on the internet. I would like to hear your opinion about protein supplements in general. Whey, casein, I found them necessary to cover with lots of insulin. Would like to use them because they help recovery and are convenient sometimes instead of real food. Well, I don't know what kind of recovery they help you with. Whey protein is usually safe. Egg protein is also safe, and they both have the right assortment of amino acids to fulfill human nutritional needs. There are catches to protein powders, however. To my knowledge, there's only one state in the union that regulates the content of protein powder supplements, and that is California. There could be all kinds of additives, pollutants, and whatever in food supplements that are not regulated. So I would recommend that whatever you buy should be made in California, and that there are many supplements made in California that are low in carbohydrate. So what you do is pick a brand that's low in carbohydrate. I have a sample in my office that I use for people with gastroparesis that has something like 3 ounces of protein per scoop and 1 gram of carbohydrate per scoop. I'm a 50-year-old type 1 diabetic, had it for 26 years. I guess this is another survivor. My question is about Dr. Stephen Gundry's plant paradox and his low lectin diet to reduce inflammation. For 3 years, I've had difficulty with plantar fasciitis, back pain, and brain fog. Since normalizing my blood sugars, I have reversed early diabetic retinopathy and now eager to improve this problem with my feet and back and brain. Your thoughts on inflammation and lectin? The foods that I recommend in my book, some contain some levels of lectin, but they don't seem to have any special effects on people. Remember that to reverse the complications of diabetes, you need normal blood sugars. And I doubt that the plant paradox is going to take care of your problems. I have a little strap that I've used for patients who have plantar fasciitis, where we've cured it in a matter of days. Brain fog could relate to high blood sugars or low blood sugars. I doubt that this magical answer is going to reverse complications of diabetes. In fact, I've repeatedly said, don't look for magical answers. They ain't going to work. I lost one of my maxillary teeth to periodontitis before being diagnosed as type 2 with an A1C of 5.8 4 months ago. By the way, 5.8 is an average blood sugar of about 132 milligrams per deciliter. I follow your methods and maintain blood sugars between 80 and 100. My gum bleeding and gum ache has now stopped. With normal blood sugars, is there a chance my periodontitis can reverse or at least not get any worse? Well, I would suggest that you see a periodontist. Once you have an infection, just normalizing blood sugars is not necessarily going to cure it. And if the infection has spread to the jawbone, it's certainly not going to cure it. So you should get a periodontist, let him see what's going on in there. They do have antibiotic packets that they put inside the gum that usually cures the periodontitis. But if it's spread to the jawbone, you probably have to be on oral antibiotics for an extended period of time till the bone heals, and that could be a year or longer. And we talk about that in the book. We have, I believe, a whole chapter on that. I am a female type 1 for 8 years, age 54, and am extremely sensitive to fructose and all sweeteners, natural and synthetic. I doubt that the synthetic are causing her blood sugar problems. They shoot my sugar through the roof even after allowing for the carbs listed in foods. Is this a diabetic thing that other type 1s experience, or is it a leaky gut syndrome? I'm avoiding these foods. Is avoiding these foods best, or is there a solution for this sensitivity? Well, my guess is that the synthetic sweeteners that you're using are powdered. And as we all know, or should know, the powdered sweeteners use bulking agents. And what bulking agents do they use? They use sugars. The most commonly used sugar is a cheap one called glucose, and it's sure to raise blood sugar. So if you're going to use a powdered sweetener, there's a good chance that you're consuming glucose. Some of the sweeteners use fructose, which is more expensive than glucose. So they're less likely to use it. And that will also raise blood sugar, but not as rapidly as glucose will. As far as the other sweet foods, you certainly shouldn't be taking them if you're diabetic. I suggest you read my book, Diabetes Solution, and learn a little more about the foods you should and shouldn't be eating. At what point after a meal should a blood glucose measurement be taken so that a proper high is measured? I understand that in your book you mentioned 2 hours after a meal. Does it mean that if the high value happens before 2 hours, it can be ignored? Also, is the 2 hour point after starting the meal or at the end of the meal? I would say you try to find out what point is the highest. and that's trial and error. And I'm sure it varies with the individual. With people with severe gastroparesis, it might not occur until the next day. Basically, if you really want to catch the high, you have to, number one, have consistent meals, very consistent meals, so that they empty your stomach the same way every day if you don't have gastroparesis. And two, that you try it at different times until you find where the high is. And then you want to prevent that high by adjusting the meal composition, the timing of your insulin if you're taking it, and so on. Recently, I have tested positive for protein and microscopic blood in my urine, and I'm wondering if it may have been untreated hypothyroidism for years and is now impacting my kidneys. My doctor says TSH would have to be very high to be linked on impact in my kidneys. Oh boy. Well, first of all, the first thing I think of when I hear of blood and protein in the urine is kidney stones. And when you talk of protein, it's important to know, are you talking albumin or globulin? It seems, according to a recent study that we published, that in a very large sample population, 40% of women and 32% of men have high amounts of globulin in their urine, and we don't know why yet. So that, if it's globulin, it could be benign. That's one thing. If it's albumin, it could be kidney damage. It could even be kidney stones. So I would say that you should get a microscopic exam looking for crystals, which would suggest the presence of kidney stones. You also could check your 24-hour urine oxalate level and citrate level. A high citrate implies a lower likelihood of stones, and a high oxalate level implies a high likelihood of stones. So that's about all I could think of right now. There may be other things to look at. Is a slight increase in serum BUN and creatinine normal on your diet, even when blood sugars are normal? I would not expect either of these to increase, but if you exercise the day before, even 2 days before the blood test, you could have elevated BUN and or creatinine, especially the BUN. Also, dehydration can cause an elevated BUN. And if it's a slight increase, you should repeat it, because slight changes can occur from day to day and from one lab to another. It just could be an artifact of the testing. According to Clinical Nutrition Guideline for overweight and obese adults with type 2 diabetes, pre-diabetes or those at high risk for developing type 2 diabetes, October 19th, 2016, Joslin Diabetes Center and Joslin Clinic. I need a minimum of 130 grams of carbohydrate per day. I am currently trying to eat at least half of these per day. If I eat more than 50 grams, my blood sugar shoots up to 200. What should I do? I'd suggest that if you want to investigate, you could follow the dollars just like as they did with the investigation of Watergate. And what you'll find is that there was bribery involved, and this bribery was first documented in 1965 and continues to the present day, and is an effort to put the blame for heart disease and strokes on fats instead of carbohydrate. And we now know that the real culprit is carbohydrate, and there have been big payoffs. This was documented by an article in the Journal of the American Medical Association about a year ago, and it's well near forgotten by now, but the world had a rude awakening when that was published. I've had type 1 for 43 years and use a pump. I had elective surgery 2 years ago and was told they had to switch my pump to a glucose drip and insulin drip. I told the staff there was no way, there was way too much insulin, but they instead coded and narrowly but they insisted. I coded and narrowly avoided deaths due to hypoglycemia. I now need more surgery. Please help me as to how to manage my pre and post operative blood sugars. I suggest that you read my book, Diabetes Solution. There is a sample letter in there that you can have your surgeon sign. It instructs him on how you want your diabetes treated. You should certainly be receiving the same basal insulin that you currently get if you're well controlled. Now, one big problem is that you're on a pump, and most people on pumps are poorly controlled and really don't know what their basal insulin should be. So there are some real problems. Certainly, you shouldn't be receiving glucose unless your blood sugar drops too low. You can pick a target for that. You might want it to be 90 or 85 or 70. And you could tell them how much glucose to give for a particular low blood sugar value and what the target should be. All of this is covered in my book, and in theory, at least, you should be able to figure things out. I had similar problem. I had surgery several years ago, and they tried to kill me at least 5 times, and I had to intervene every step of the way. A great big giant guy who could easily beat me up hooked me up to a glucose infusion, and he wouldn't turn it off. He said it's the hospital policy, and as soon as he turned away and walked away, I closed the clamp myself. And I had to intervene on several occasions, and even get the help of a nurse who had used my book to treat her husband. So it's pretty hard surviving in a hospital if you're diabetic. Well, that's it for tonight. Our next teleseminar will be Wednesday, December 27th, and that will be the last one for the year 2017. Have happy holidays, and we'll wish you a happy new year when we see you next. Thank you.